It's really a pleasure for me to be speaking before you today, and quite an honor to have been invited to give the 20th Kaye Lecture and Learning Day. And for my topic for this, if you will, keynote lecture, I'm going to talk about what I call a comprehensive approach to vertical strabismus. And this disclaimer, I have it on the intro slide for each talk. I'm on the scientific advisory board of a biomedical company, and I can say at the outset that that relationship does not have any bearing on any of the talks I'm giving with respect to any conflict. But before I launch directly into the material, I just want to say a word about the Kayes. This is a day in many ways honoring Olga, Ludwig, and Connie Kaye. This is a picture of Olga Kaye. Her husband, Ludwig, passed away some years ago. And Olga and Ludwig had daughter Connie, who was a child with multiple medical needs, many of which were ophthalmologic in nature. And as I understand it, she really received a lifetime of good care at your institution, specifically in the eye department. And it was to honor Connie that Olga and Ludwig set up this endowment for the Kaye Learning Day and the Kaye Lectureship. And I think this is absolutely wonderful. I think of this form of generosity, as the expression goes, as paying it forward. So I'm going to dedicate this talk to the three Kayes. And moving on into the topic, we're going to talk about vertical strabismus, what I call a comprehensive approach. Comprehensive because I'm going to discuss both diagnosis and treatment. Treatment, of course, one could talk all day about all aspects of vertical strabismus, but we'll touch on some of the highlights. And I want to introduce the talk with this patient who, in a way, was the index case of my getting really interested in this subject. Turn the clock back to 1976. I was in the operating room, and I get a message that this very well-known, very famous on-campus university professor and department chair is in the emergency room. He was in a motor vehicle accident. He was momentarily unconscious, and upon awakening, he complained of double vision. Well, I'm scrubbed, so I send the resident down to take a look at him and report back to me. And the resident comes back and says, well, I think he has a left superior oblique palsy. I say, why do you say that? Well, he has a left hypertropia, and it increases on right gaze and on left head tilt. Let's take a peek at how he looked. And I think the video is okay. This, bear in mind, was filmed on 16 millimeter film and then later digitized. So, but I think the quality holds up. This man developed double vision after a motor vehicle accident. He has a left hypertropia, which increases in right gaze. It also increases on left head tilt, meeting the three-step criteria for a left superior oblique palsy. In fact, he has an orbital floor fracture in the right eye and fixes with the right eye because of mild amblyopia in his left eye. So that launches us into a discussion about the three-step test and what I'll just use the broad brush to call errors with the three-step test. The three-step test is predicated on the assumption, and it's an assumption, that there's a palsy of one vertical muscle. And of course, there are many causes of vertical strabismus that are other than a palsy of one muscle. And we've just seen an example of restriction that is one possible cause of verticals. Multiple muscle involvement. So here are the measurements of a patient with a classic right superior oblique palsy. It's a right hyper. It increases on left gaze. It increases on right head tilt. But, and that's the three-step test right there. But if we fill in the oblique fields, we see a reversal of the hyper up and left. And of course, if there's a left hyper in any field of gaze, we're dealing with something other than just a right superior oblique palsy. And of course, if we add torsional measurements, we see there's a total of 17 degrees of X cyclo, split not equally, but between the two eyes. 17 is far more than what one would see with a unilateral problem, which usually is 7, 8, rarely, if ever, more than 10. And the three-step test assumes, again, there's a palsy of one muscle. Prior surgery. So if a patient had prior vertical surgery, there's a good likelihood they had a muscle recessed or resected, and now we're dealing with an iatrogenic additional palsy muscle, perhaps of the yoke of the initially paretic muscle. So prior surgery puts the patient in the same category as multiple muscles. You can't apply the three-step test. DVD, this is very interesting. Classically, DVD behaves opposite of superior oblique palsy with respect to head tilt. Here's a left hyper, and DVD often increases in adduction because they say the nose blocks the eye, acts as an occluder. I'm not sure that's the mechanism, but suffice it to say it often does. And classically, a left DVD will increase on right head tilt and decrease on left head tilt, the opposite of a superior oblique palsy. But that's only classically. I did a prospective study looking at DVD and head tilts and found that in the cohort that I had, 57% increased on contralateral tilt. Let's watch this. This woman has DVD greater in her left eye than her right. She shows the classic response to head tilt. Her right DVD increases on left head tilt, and her left DVD increases on right head tilt. So that's classic, but in my experience, it only occurs in a little more than half of patients. In this study that I did, 19% had what I called an atypical or paradoxical response, in that the DVD increased on ipsilateral tilt. And about a fourth of them, 24%, had no change in the DVD on head tilt either right or left. And I tried to correlate this with whether the patient also had true oblique dysfunction or other factors, and I really could not find any underlying mechanism that explained these differences. So I showed you the classic. This is an example of the atypical, left DVD increasing on left head tilt. And as I recall, there's no audio on this one. So we saw DVD, bilateral DVD. And he's increasing the way it would were that left hyper a superior oblique palsy. Skew deviation. I won't say a lot about skew, other than when you have a hyper and the torsion that you see doesn't fit the motility pattern, think of skew. And of course, the supine head tilt test, which Agnes Wong described or popularized, has become kind of the standard for diagnosing this. It's when the hyper decreases substantially when the patient is supine. But for the purpose we're talking about right now, skew can give you a misleading diagnosis when you apply the three-step test. Myasthenia. Myasthenia can mimic any palsy of any extraocular muscle. And of course, you could have a myasthenic superior oblique palsy, if you will, but the real diagnosis you want to get at is myasthenia, not just that the patient has a superior oblique palsy. And last in this discussion, I want to talk about these small hypers that so commonly accompany horizontal deviations. You know, you have a patient with a 30 prism diopter ET or XT, and they've got 2 or 4 of vertical on one eye higher than the other. And you do a head tilt test, and there's a slightly positive Wilczewski head tilt test. Is the 3-step test appropriate here? Are you dealing with whatever the 3-step test steps out to? Well, probably not. And this slide depicts what is probably going on. I may be misattributing this. I think it was Ricky Cohen and Sally Moore that published this article. It's not my original observation, and I hope I'm not giving attribution to wrong individuals. But let me explain the mechanism. Let's take this hypothetical patient that is esotropic. And I'll say up front, let's say hypothetically, the superior rectus and the superior oblique are normal, not paretic, not overacting. When the eye is esotropic, it's more in the field of action of the vertical vector of the superior oblique than the superior rectus. So on head tilt to the right, with normal innervation to these 2 vertical muscles, you're going to get more depression from the superior oblique than elevation from the superior rectus, mainly because of the position of the, not mainly, solely because of the position of the eye. And with an exotropic patient, the opposite occurs. The eye is more in the field of vertical action of the superior rectus than the superior oblique. The superior rectus elevates, elevating power will overpower the superior oblique, which is anatomically now in a deprived position with respect to the location of the visual axis. And in fact, after I saw their article, when I looked at my patients for a while with this in mind, I found there was a congruence that this mechanism did seem to be frequently at play. So that's something also to bear in mind. Now, the 3-step test is notoriously inaccurate for vertical rectus palsies. And there are several reasons for that, I think. One, and I'll demonstrate this in a minute, the inferior oblique, interestingly, cannot elevate the eye above the midline if it's the only elevator functioning. And conversely, the superior oblique alone, if it's the only depressor functioning, can't depress below the midline. And both would be required by the 3-step test with a vertical rectus palsy. Now, you'll see this is a video, and this was loaned to me, given to me by Art Jampolsky. And it's interesting as I prepared my lectures how very frequently his name comes up as an individual that I'm giving attribution to. He certainly made his mark, certainly on me, but on our field. So this was digitized from initial 16mm film, so the quality speaks for itself, but I think it's adequate. Let's see what this shows. Oh, missed that. This shows someone undergoing strabismus surgery under topical anesthesia. The head is at the top of your screen. Vertical saccades are normal. The superior rectus muscle is disinserted in the usual manner. Testing shows the superior rectus is completely detached from the globe. Afterwards, the eye can make brisk saccades from below to the midline position, but cannot elevate above midline. So that's something that until Art Jampolsky showed me this was something I was unaware of, but I think that it does bear out partly why this three-step test is inaccurate. And also, I think it's just an interesting observation that the oblique muscles can't elevate or depress past the midline if they're functioning by themselves. And then, in addition, or finally, the three-step test is inaccurate with vertical muscle overaction. We so often think in terms of everything being due to an underaction. And if you really delve into muscle physiology, you'll realize there are situations where muscles can be, quote, overly strong. By that, I don't mean tight. I mean overly strong, that a given amount of innervation causes a greater amount of contraction than in a normal muscle. And again, the three-step test assumes there's a palsy. Now, you'll see in a second a video, and this also does not have audio on it. This is a woman who has in primary, very small left hyper. It's due to marcaine toxicity, secondary to an injection, which affected the left superior rectus muscle, and that was confirmed by orbital imaging. So just a flick of a left hyper. But bigger on left tilt. And if you watch reversions, when she gets up in the field of the left superior rectus, you'll see the hyper take off. And as I said, imaging shows she had an injection to the left eye superiorly, peribulbar, and imaging shows a large hypertrophied superior rectus muscle. Okay, so that's the errors in the three-step test. Let's just look at some other things here. Is this an overacting right inferior oblique? Most people would probably say it is. That term implies an etiology, and many things can cause the picture we're looking at right now, and I'm going to show you some examples thereof, that are not caused by the inferior oblique. And although I'm as guilty as probably anybody of slipping into the old terminology, it would probably be better to just refer to this as over-elevation or over-depression of the muscle, of the eye in adduction, rather than implying the etiology. So we're going to look first at what I labeled pseudo-inferior oblique overaction. And this is a video of actually the index case, the first person I saw or identified with this condition. And it's very interesting when I'll tell you a little about her before you see how marked her motility disturbance is. She was the older sister of a patient of mine with infantile esotropia. And whenever the family would come in, parents were both teachers, and they'd always come in on Easter break or, Thanksgiving holiday break, and they'd bring the sister along. And one year, they said to me, I think Joan was about 5 years old at the time. They said, well, should you examine the sister, Joan? I said, well, does she have any problem? They said, no. So I just went over and I took out a pen light and said, just, follow this. And you'll see what I saw. This girl was asymptomatic, but found on routine exam to have this impressive motility disorder. There is a Y pattern with marks splaying out of each eye with elevation and adduction. It resembles inferior oblique overaction. However, despite this significant apparent inferior oblique overaction, there is no superior oblique underaction, no elevation on direct horizontal side gaze, and no fundus torsion. This is pseudo-inferior oblique overaction. So I actually still followed this girl up until a couple of years ago. she's now about 37 years old. She's never been bothered by this, never noted any symptoms. She says no one has ever noticed it, which I find a little hard to believe, but that's what she said. And it's been completely stable. And the important thing about this to note is that weakening the inferior obliques does absolutely nothing. I've seen a handful of patients where this was not recognized by the initial treating doctor, did inferior oblique weakening, either recession or myectomy, and there wasn't one iota of change, other than in a couple of patients, they induced it in cyclotropia. It's probably a variant of the co-contraction syndrome. It's perhaps could come under the broad mantle of a variant of Duane's. I think there's aberrant innervation to the lateral rectus on elevation and adduction. Pseudo-inferior oblique overaction, and weakening the inferior obliques does nothing. Now, this is similar, but this is the anti-elevation syndrome. And this is what can occur after an inferior oblique anterior transposition, particularly if the inferior oblique is sutured anterior to the inferior rectus insertion, or if the posterior temporal corner of the inferior oblique is spread out laterally. So this also was the index case. I did not do her surgery. In her case, the inferior obliques were put, I think it was anterior to the inferior rectus. It was either 2 or 3 millimeters anterior to the inferior rectus. Let's watch. When viewed on elevation and side gaze, this girl appears to have inferior oblique overaction. In fact, she has bilateral anti-elevation syndrome. As an infant, she underwent bilateral inferior oblique anterior transposition, placing them anterior to the inferior rectus insertion. What looks like inferior oblique overaction is over-elevation due to fixation duress. The abducting eye is restricted to elevation in abduction. So here's what I think is going on. This is a surgical, an artist drawing of the inferior oblique anterior transposition from one of the studies that David Steger did on this subject. And it's thought, he thinks, that when the inferior oblique is anteriorly transposed, the neurofibrobascular bundle, this structure here, acts in a way as the functional origin of this transposed tissue. So you'll see, given the way it's laying, that when the eye is slightly in abduction, the visual axis is parallel to these fibers. And that's why, even though the inferior oblique's field of vertical action is greatest in adduction, the restrictive or anti-elevating effect of this transposed muscle is greater in abduction than adduction. Important to know about this is forced ductions are normal. This is what I call, for lack of a better term, an innervational restriction. On attempted elevation, this tissue, this muscle contracts and puts a brake on elevation. So it causes a restriction. But in the not in the state of innervating elevation, there is not a mechanical restriction. And this is just a still photo of another child with that. You see no real significant elevation on side gaze, but this marked splaying out on up gaze. And what's really happening here is there's a restriction of, if we look up and right, this eye going up, this one kind of overshoots. It's the anti-elevation syndrome. And of course, you all know Duane syndrome can present with an upshoot or a downshoot. When viewed in left gaze, this looks like an overacting right inferior oblique. In fact, this girl has Duane syndrome in her right eye. there is limited abduction of the right eye, and on adduction above the midline, there is an upshoot, and on attempted adduction below the midline, there is a downshoot of the right eye. Let me see it. On adduction, classic globe retraction can be seen. And of course, in almost all cases in Duane syndrome, that the upshoot or downshoot is not caused by the oblique muscles. It's thought to be an escape mechanism. On attempted adduction, the lateral co-contracts, and it could either pull the eye back in the eye socket, in the orbit, or it can slip up if it's above the crest, or slip down as a release mechanism, and that causes a downshoot or an upshoot, depending on whether it slipped up or down. And then more recently described are pulley issues. And I honestly am not sure how prevalent they are. The literature suggests they're increasingly more widely recognized and more conditions are attributed to them. But I've certainly seen some cases. This is a 17-year-old boy who developed a sudden onset of diplopia on left gaze. And he's pretty much okay in primary and the other fields, but when he looks to the left eye slips down. And if we do coronal imaging, we'll see that the left lateral rectus is low compared to the right. The line drawn through the top of the lateral rectus here is just about at the middle of the lateral rectus of the right eye. And this pattern was in fact fixed by not just even disinserting, but raising the belly of the lateral rectus near the equator and fixating it to the globe. Okay, DVD. We talked about it a little. I'm going to say a little bit more about it. This boy has over elevation of either eye on adduction. Cover testing in side gaze does not show a hypotropia of the abducted eye. This over elevation is due to DVD. Contrast that with this boy. He does show DVD in primary gaze. He also shows over elevation of either eye on adduction. However, in this child, cover testing in side gaze shows a hypotropia of the abducted eye. This boy has true inferior oblique overaction coexisting with DVD. And shortly, as I move into the treatment phase, of the talk, we'll talk about how I like to manage them differently. But it's very important when you're evaluating a patient with DVD and you see the upshoot and adduction to determine if it could be the inferior oblique causing it, or if it's just the DVD becoming manifested. And of course, there can be element of both. You can have a patient where, let's say when they look, in this case, to the left, the hyper of this eye, the right eye, is greater than the hypo we see in the left eye when the right eye is fixing. And that means all of the elevation and adduction is not due to the inferior oblique. It's a combination of the DVD and the inferior oblique. And you want to make those assessments before you sort out your treatment plan. So here's a girl with DVD. And we see when we look behind the cover, when we cover that abducting right eye, we see it goes up. This is a patient with what looks like an overacting inferior oblique that's really due to DVD. And then kind of nearing the end of the diagnosis part of this talk, we're going to talk a little bit about measuring torsion. There are two types of torsion. measurements we can make, objective and subjective. And I've often been asked, well, which is a better one to do? And the answer is both. They tell us different things. So objective torsion is determined by looking at the fundus. And studies have shown that in the normal subject, patient with normal motility, the fovea lies between these two imaginary lines, one level with the bottom of the disc and one at the junction of the lower third and upper two-thirds. The original studies done by von Orden, and I think Guyton co-authored them, said that this upper line should be at the middle of the disc, the junction of the upper and lower half. And subsequent studies, and I think that they're correct, show that's not the proper position. So if the fovea is above this line, as seen with the either in fundus photograph or with the ophthalmoscope, you're dealing with intorsion, and if it's below, it's extorsion. Objective torsion is better for determining which eye or to what degree each eye has the actual motility problem. So examples of a markedly excyclorotated eye, the fovea is way down, 15 degrees, I think it's below the normative line there. And here's a markedly encyclorotated eye. Here's the threshold for the upper limit of normal. So that's intorsion and extorsion. Now, subjective torsion is what we measure commonly with the double Maddox rod. There are other ways to do it. It can be done with the synoptophore. There are various subjective cyclophotometers, but the double Maddox rod, I'll say, is classic. And the classic description of it was to use a red and white Maddox rod. And a study done by Kyle Arnaldi and I think Jim Reynolds really convinced me to use two red Maddox rods. And what they found is that there's a subjective tendency to localize the torsion to the eye that has the white Maddox rod in front of it, whether that's the paretic eye or not, or at least to lean towards seeing more of it in the eye with the red than the white. Presumably, there are more peripheral clues from the environment that can be seen with the white lens. So I use two reds. Even with two reds, it's less accurate in identifying which is the torted eye, particularly if a patient has a very strong fixation preference. If that eye has the cyclovertical torsion problem, there's a tendency to localize it to the other eye. But unlike fundus torsion, it's the only thing that identifies symptoms that need treatment. You know, we could have a patient with infantile esotropia and inferior oblique overaction and marked fundus excyclo. You don't have to correct that cyclo. You may want to do the obliques to correct the motility pattern, but as far as actually correcting torsion, it's probably not necessary. But if there are symptoms, you need to correct them. You want to correct them. And fundus torsion is not helpful for telling you that. It may help you determine a plan, but not whether you should do it or not. And if there's a bilateral problem, the double Maddox rod, I think, is useful for telling the total amount of torsion. I don't completely rely on, like the slide I showed earlier with the bilateral superior oblique palsy, where it's at 12 in one eye, 5 in the other. Patient, you know, probably had about 8 in each eye, or 7, 8.5 in each eye, but the way it's split may not reflect the anatomic problem. So if it's bilateral problem, think in terms of total torsion. Don't disregard how they localize it, but don't put too much stock in it either. Whenever you're seeing a patient with unequal vision, always consider the possibility that they're fixing with the involved eye. This is a patient that actually has a right superior oblique palsy, fixes with the right eye because of amblyopia in the left eye, and has what's sometimes referred to as the fallen eye syndrome. So what we see is he had a left hypo, never manifests a right hyper because he always fixes with the right eye. And I have seen patients that fixed with the affected eye with virtually everything vertical condition you can think of. I've seen Duane syndrome, Brahms syndrome, Graves' disease, monocular elevation deficiency, and so on. Always have your antenna up. Whenever the patient has unequal vision, at least ask yourself that question. Okay, now any discussion of vertical strabismus, and we're slowly moving into the treatment phase, has to talk about exaggerated force ductions for the oblique muscles, which was described and popularized by Dave Guyton. And this video was courtesy of Dave. This is actually the one he originally used to present this material at the APOS meeting. It's been edited a bit, so the voice overlay is not Dave speaking, it's me. We're going to be seeing the left eye of a patient seen from above. Horizontal force ductions in the usual manner are normal. To test for torsional restriction, it helps to retropulse the globe, which puts the oblique muscles on stretch. Rotary force ductions can be done in this manner to look for a torsional restriction. Look for symmetry. To test for oblique muscle tightness, grab the eye at 3 and 9 o'clock. For the superior oblique, push the nasal force up into the superior nasal quadrant and rock the eye temporally in this manner. You can see and feel the eye roll over the superior oblique tendon. For the inferior oblique, do the same in the inferior nasal quadrant. This amount of tightness is normal. We are now going to see a patient with superior oblique overaction and a pattern. When testing for the superior oblique, you can see this marked 3+ restriction as the eye rolls over the tight superior oblique. The inferior oblique is normal. Look at the eye just snap over the superior oblique. Bilateral superior oblique tenotomies were performed and the maneuver repeated. The eye now moves freely when testing for the superior oblique, indicating that the tenotomy was complete. So subsequent to the original description, I and others, perhaps David Guyton, I'm not sure, have switched to just using one forcep, which works as well in the superior inferior nasal quadrant. So this is useful at surgery, both to determine if the muscle or tendon is tight or lax, but also after surgery, if you've disinserted the inferior oblique or done whatever you do to weaken the superior oblique, to repeat and see if your surgery is complete. The exaggerated force duction should then normalize. And this was mentioned on the video. I actually don't retropulse as much as David showed in the video. This is rotary force ductions. It's different than the exaggerated force duction. You just grab the eye at either 3 and 9 or 6 and 12 o'clock. Here they were 6 and 12. And you just rotate the eye clockwise and counterclockwise and look for symmetry. Here you can see we can rotate the eye further in the clockwise direction than we can here. And that tells if there's a torsional restriction. And that can be very useful during surgery and sorting out what to be doing. So we've talked a lot about diagnosis. I want to spend a little time talking about treatment principles. obviously we're not going to be able to cover every conceivable form of vertical strabismus, but I'm going to talk about a couple of the more common ones. But first, some general principles that I think apply to all cases of vertical strabismus. In diplopia-aware patients, primary position and down gaze are most important. So ideally, you want to get patients, diplopia-free and looking good in all fields of gaze. But if you have to make decisions, trade-offs, don't sacrifice primary and secondarily down gaze for up gaze or side gaze. Choose your muscle that you're going to operate to match the motility pattern. You want to choose muscles that will give you the greatest correction in the field of the greatest deviation. That's Strabismus 101. In that, however, you want to consider torsion if it's a diplopia-aware patient, because sometimes a muscle choice that would most address the vertical and or horizontal pattern may not address torsion or may actually worsen the torsion. So you want to take that into account. And finally, if you're dealing with a paresis of a muscle, you can often weaken the yoke muscle unless the palsy muscle is -3 to -4 in the field of action that we're talking about. So I want to start by talking about my approach to superior oblique palsy. And it's different than, certainly different than Knapp's classification, and it's not as formulaic as just do an inferior oblique for every patient, but it's worked well for me. So the first thing I do is I dichotomize, is this a one muscle procedure or more than one? And I make that judgment based on the primary position measurement, because above all, I don't want to overcorrect primary. So if the patient is, let's say, under about 15 prism diopters in primary, I'll do one muscle in most cases, regardless of what they are on side gaze, because I don't want to operate for a very large adducted field measurement if that's going to overcorrect primary. And if it's 15 prism diopters or more, I will typically do two muscles, and on rare occasions, a third if it's a really big deviation. Now, these aren't firm guidelines. If it's an adult and a patient I can do an adjustable suture on, and if there are reasons I may want to invoke another muscle because of the pattern, I may have that cut off at 10 or 12 prism diopters. If I feel by putting a muscle on an adjustable suture, I can bail out an inadvertent overcorrection. So that's step one. Is it a one muscle or more than one muscle? So let's look at different patterns now. So here we have, it's a one muscle procedure. It's under 15 prism diopters in primary. And this, in my experience, is the most common presentation for patients coming to surgery, which is after, if it's acquired, we've waited the requisite 6 months. Biggest deviation in the field of the inferior oblique, and somewhat less down here. I'll weaken the inferior oblique. I think most people would do that. Still a one muscle procedure under 15, but it's big all across the board here in the adducted field. It's as big in up gaze as it is in down gaze. Under one muscle procedure, I'm still going to do the inferior oblique. Now, what about still a one muscle procedure, biggest in the field of the superior oblique? Well, this is a classic example of when a superior oblique tuck is an appropriate procedure. In my way of viewing this subject, and I may have another slide that accentuates this, but I'll talk about it now because it's relevant. Tendon laxity does not play a role in my decision whether to tuck the muscle or not, tuck the tendon or not. You know, there's a dogma. Lax tendon, you have to tuck it. Non-lax tendon, you can't tuck it. And to me, this is illogical. Studies have shown, nice study from Japan, Mio Sato did this, where they did orbital imaging on congenital superior oblique palsies with lax tendons. And most of them, all of them, had either agenesis, some, or more severe atrophy of the superior oblique muscle belly. So the dogma is based on the I think misconception that the problem is an elongated tendon. It's not. It's a paretic or paralytic or absent muscle. So to say if it's a lax tendon, you need to tuck it makes as much sense to me as saying if there's a lateral rectus palsy with a paralysis, with a completely dead, flaccid lateral rectus, you have to resect it. And if there's function to it, that's the parallel of a non-lax superior oblique tendon, don't resect it, when in fact we do the opposite. Now, there are some people, many people, that just don't like to do superior oblique tucks. They're not comfortable doing them. They don't feel they get good results, and they like to avoid it. In this pattern, if you don't like to do tucks, I personally do, but if you don't, you can almost always duck the tuck, as they say, by recessing the contralateral inferior rectus. That'll address the pattern, but it won't completely correct the torsion. Simultaneously do a nasal transposition of the right inferior rectus without recession to address the torsion. And I think in almost all cases you can get by without doing a tuck. Now we're talking about two muscle procedures. We're more than 15. I'll weaken the inferior oblique and recess the contralateral inferior rectus on an adjustable suture with this common pattern, similarly with this pattern of the deviation all across the adducted field, and also same procedure if we've got it all across the board here, adducted field and down gaze. With one caveat, and especially if you see a big deviation down here, look in the horizontal abducted field. And if you're dealing with 10 or more of hyper, you probably have superior rectus contracture. A superior oblique palsy in the acute phase will give you almost no vertical in the horizontal abducted field. And if it's 10 or more, there's probably something going on with the superior rectus. And for reasons which I don't have time to explain here, but there's been publications on this, for some reason, the superior rectus in this situation behaves more like an overacting muscle than a contractured muscle. As such, forced suctions are frequently not markedly positive. But if I see this, if I see more than 10, I'll do the inferior oblique plus a small superior rectus recession. But I want to emphasize the fact small because when you're weakening both elevators, so I'm talking 2.5 millimeters, depending on forced suctions, weakening both elevators is very powerful and you can cripple up gaze. Okay, moving on to DVD. DVD, I dichotomize treatment, not whether it's bilateral DVD or not, but whether it's bilaterally manifested. The most common presentation for DVD, in my experience, is both eyes go up under cover, but only one eye goes up on its own. That's unilaterally manifest, but bilaterally present. And whether there's equal vision with potential to switch fixation. And finally, my treatment is influenced by whether there's inferior oblique overaction or not. And we talked about how to determine that, hypo of the abducting eye and side gaze, and the presence of X-cycle torsion would lean me toward that. So if it's bilaterally manifest, now by definition, that would mean equal vision, because if either eye goes up, the patient is sometimes fixing with the right and sometimes the left. So the vision is going to be close to equal. I'll do bilateral surgery. If the inferior obliques are overacting and it's bilaterally manifest, I'll do bilateral inferior oblique anterior transposition. If the inferior obliques are not overacting, I do bilateral superior rectus recessions. And I will do them symmetrically if the angle and large amounts, because if I operate on both eyes, what I do in the fixing eye is in a way negating what's happening in the other eye. So that's where I do bilateral 8s or 9s or something like that. If it's approximately symmetric. If it's very asymmetric, I'll do asymmetric surgery if the angles are very unequal. So unilaterally manifest, contralaterally present is most common. Equal vision bilateral surgery, I just went over that. I do not do, if it's, if it's unilaterally manifest, inferior oblique overaction is absent, I'll do superior rectus recessions. If inferior oblique overaction is present, but it's unilaterally manifest and there's unequal vision, so they're not going to shift fixation, I don't do unilateral inferior oblique anterior transposition. In fact, I essentially never do that. And I'll go over the reasons for that shortly. So this is just a summary. DVD, no inferior oblique overaction, manifest unilaterally, equal vision, bilateral asymmetric superior rectus recessions. I think I had this confused on the previous slide. Unequal vision, unilateral recessions. If it's manifest bilaterally, no inferior oblique overaction, bilateral superior rectus recessions with large numbers. If there's DVD and inferior oblique overaction, yes, present. If it's manifested unilaterally, if there's equal vision, so they may shift fixation, I want to do bilateral surgery, I'll do inferior oblique anterior transposition. Unequal vision, unilateral recession, and my numbers are smaller than when I'm doing bilaterally. If it's bilaterally manifest, which would mean equal vision, bilateral inferior oblique anterior transposition. Now, we talked about the anti-elevation syndrome, and it's thought to be caused by where this corner of the inferior oblique is placed, if it's spread out laterally, or if I go anterior to the inferior rectus. I've subsequently switched my technique to only suturing this corner to the sclera, level with the inferior rectus, and letting this corner hang back to wherever it's going to hang to. I've never had anti-elevation syndrome after having switched to this technique. However, it's a less powerful operation for DVD. So it's a trade-off. If I want to minimize anti-elevation syndrome, I'm getting less DVD correction. If I want to get more DVD correction, I'm increasing the likelihood of anti-elevation syndrome. Here's why I don't do the inferior oblique anterior transposition unilaterally. This teenage girl came in to see me, and her chief complaint was her left eye looks smaller than the right. And she had undergone, some years earlier, a left inferior oblique anterior transposition for superior oblique palsy. I think it's a bad operation for superior oblique palsy, but nevertheless, that's what she had. It narrows the fissure predictably. This patient, and interestingly, the surgeon who operated on her is the same one who did the index case of the anti-elevation syndrome. He said he recessed her superior rectus muscles for DVD and had no lid problem. And then he did large anterior transpositions to the inferior oblique, and she has upper lid retraction. Couldn't understand that. And if you look at it, the reason is you can't look up. Look at the brows. She's struggling to get the eyes in upgaze, and they hardly go up at all. In a prospective study, we saw that very predictably inferior oblique anterior transposition causes a bulge of the lower lid on upgaze and a flattening of the lid curvature. And the lower lid elevates more than usual on upgaze. Now, unilaterally, patients do not complain about this, but I'm sorry, bilaterally, but unilaterally, it can be a cosmetic problem. And the study showed it narrowed the fissure predictably between 1.2 to 2.1 millimeters and caused the other lid problems I mentioned. So we're getting close to the end. In summary, we talked about diagnosis. The history can help. You want to determine if it's DVD. Is there fixation with the involved eye? Always think of that when there's unequal vision. The pattern will help with the diagnosis. Errors in the three-step test. Treatment, choose the muscle to match the pattern, release restrictions, weaken yoke, and consider torsion. I'll leave you with just a couple soft signs. If the incomitance pattern is larger vertically, in other words, the difference between upgaze and downgaze is greater than the difference between right and left gaze, think of a vertical rectus problem or a restriction. And if the incomitance pattern is larger from right to left, think of an oblique muscle problem. If the forced head tilt difference is very large, think of an oblique problem or DVD. And if it's small, think of a rectus or most other causes. And this is the largest head tilt I ever saw. Here's this infant, visually inattentive, and when she's really looking, almost puts her head horizontal, and she had a complete agenesis of the superior oblique muscle. And with that, I think we're done. I thank you. Let me end the screen share.
Thank you very much, Dr. Kushner. That was very informative and really, really enjoyable. So we're going to take some questions from the floor here. So I'll just ask everybody, if you have a question, if you could please raise your hand, use that little icon there, or you can also type it in the comments, and we'll try and get to as many as we can here. Okay, so we have Dr. Aragunla.
Thank you, Dr. Kushner, for a very stimulating talk, and you've kind of questioned some old dogmas there. I have a question about anti-elevation syndrome. Can you hear me? My question is, I think I heard you say it's an innervational restriction. I used to think it was purely mechanical and to do with the tethering effect. Could you please explain that again, why you say it's innervational? So, and then I noticed also you made a surgical adaptation, the surgical technique where you use only the one corner. So could you please explain that again?
Yeah. So if you go back to think of the picture I showed, the drawing from Steger of how the muscle looks. If the muscle was tight, if it was mechanically shortened, you would have abnormal force ductions for going up. But that's not the case. What happens is on attempted elevation, the inferior oblique is innervated because normally it's innervated on attempted elevation. That causes that transposed segment to contract, to shorten. It's what muscles do when they're innervated. And that, given its new anatomic location, acts as an anti-elevator. I don't like to use the term a depressor because it doesn't depress, it just prevents elevation. It doesn't depress on attempted down gaze. On attempted up gaze, it's innervated, it shortens, and it restricts elevation. Now, people have suggested, and this has been kind of worked out with the computer modeling, and I'm not that savvy. I take with the computer model, I take people's word for it, that a cause that you're more likely to get the anti-elevation syndrome, number one, if you put it anterior to the inferior rectus because you're just getting a more powerful anti-elevating effect. But also, if you spread that posterior lateral corner out laterally. So what I started doing when I first started doing was when I would do the procedure, I bunched them. I didn't spread it out like one might do for a recession if you spread them out. I didn't, but if you do, I would bunch it. And I found, when I wrote the article on anti-elevation syndrome, I don't remember how many patients, I had X number of patients. But as years went on, I would increasingly see it in patients who didn't have it initially. The longer they went after surgery, the more likely it was to appear. Not 10 years later, but often they were okay at 2 years and not at 3 or 4 years. So they say it's the spreading out of that corner. So I just humbled to just bunching it wasn't enough to completely prevent it. I just let that go where it went. And I was happy with that. But DVD you never cure. We try and make it better. It is a less powerful procedure. It's still more powerful, I think, than superior rectus recessions. So does that answer your question?
Okay, thank you very much. Next, we have a question from Dr. Rubab.
Thank you very much, Dr. Kushner. It was really wonderful talk. Actually, I have been kind of getting some tips all along the way. My question is regarding nasal transposition of inferior rectus muscle in superior oblique palsy. How far, do you half tendon or you do full tendon transposition?
I don't have science to back this up. When I first started doing it, I first heard about it from Van Noorden. And in the oral presentation I heard, he said he would transpose 7 millimeters. So I literally take the caliper, I'd put the one corner 7 millimeters nasal to where it was, and the other one, spread out an equal distance from that. Actually, when he published the article, I think he wrote that he did 10 millimeters, but I had already been doing 7 and I was happy with it. So I've never done a comparison. I've never done more or less. I've just arbitrarily do 7 millimeters, and I've been satisfied with the effect of that.
Okay, thank you. I have one more question. How do you titrate superior rectus recession in DVD? Do you do the same amount or you have a different?
Yeah, so if I'm doing unilateral surgery, so that would be the patient that has unequal vision where I know they're not going to shift fixation. If you do, I didn't say this, and I'm glad you asked the question. If you have a patient that has by equal, I mean close to equal vision, and on the pre-op, they only manifested in one eye. If you do unilateral surgery, because only the right eye goes up, the left eye only under cover, right eye goes up, you do the right eye. Studies show, big study by Van Noorden and Bill Scott, over a third, depending on the study, between a third and half will then come in with the other eye starting to go up. They shift fixation, the other eye goes up. So but they're not going to do that if they're amblyopic. So if it's unilateral surgery, I follow a formula similar to what other people do. Bill Scott is the one who I think put it in print. It's more than your normal surgery. I think it's like 5 for 15, it goes up a millimeter per diopter, 5 for 15, 6 for 20, 7 for 25, and up to about 7 or 8. If I'm doing bilateral surgery, then, as I said, you have to do more in both eyes, because let's say one eye goes up 20 and the other eye goes up 15. If I did 6 and 5, when they're fixing with the eye I did 6 in, I've weakened there are more up-gaze innervation to fix with that. It negates what I did in the other eye. So if I'm doing bilateral, I'll usually do something like bilateral 8s, bilateral 9s. if it's symmetric, if the deviations are close to symmetric. And if they're not, I'll usually separate it by a couple millimeters, like 7 and 9 or 8 and 10, something like that. It's not a rigid formula. And if I probably went back and reviewed the last 100 I did or 50 I did, there would be some inconsistencies. I think I was more rigid in my formula for horizontal surgery. DVD is kind of a moving target and
Yes.
frustrating target.